hello there. I'm purposely not saying good morning today because being a Saturday, I have no idea what time you might be getting around to listening to this one. But welcome to the Solo Bureau Saturday special. It's World IVF Day today. So July 25 marks the same day that the first ever IVF baby was born. Her name is Louise Joy Brown. She was born in 1978, the same year that Grease came out, Christopher Reeve debuted as Superman, the Bee Gees were dominating the charts, and also this gal was born too. Yep, me. I was born in 1978. Now, it was a massive moment in scientific history. Louise's birth, obviously, not mine. The pioneers of the science, biologist and physiologist Bob Edwards, obstetrician and gynecologist Patrick Steptoe, and research assistant Jean Purdy all worked together to transfer an 8-cell fertilised embryo into Louise's mum at midnight, November 12, 1977. Louise arrived 8 months later. Now, back then, she was referred to as a test tube baby. IVF was considered quite taboo and very experimental. And while it is much more widely accepted now, there is still a bit of social stigma associated with the need to get help to get pregnant. Now, in 2026, there are believed to be, and this number did blow me away a little bit, somewhere in the vicinity of 12 million people walking this planet right now who otherwise would not have existed if it were not for in vitro fertilisation. So today is the day we not only mark the milestone of Louise's birth, but we also acknowledge the doctors, the nurses, the support staff, the families who've all helped each other go through this process, both with successful and sometimes not so successful outcomes. So in honour of today being World IVF Day, I thought I'd spend some time chatting with Associate Professor Dr. Deveni Ameratunga. She's a reproductive endocrinologist and the Medical Director at Life Fertility in Brisbane. Happy World IVF Day, Dr. Dev.
Oh, thank you. Same to you.
Welcome to the Solo Bureau. It's lovely to have you. And this is a Saturday special today, so it's just going to be you and me chatting about IVF, which you know a hell of a lot about. So, first question I need to know is, and I ask this pretty much of every medical professional that I come into contact with, because I'm so keenly interested in why they choose the specialty that they decide to end up in. Sometimes it's just happy accident and, you know, they did a rotation and it sent them in that direction. Other people really seek that out because they've been so interested in it from the very beginning. What's your story with reproductive medicine? What sent you down that pathway?
Great question. No one actually has asked me that before.
There you go.
So well done. I guess like 50,000 years ago when I was a physiotherapist, I was always interested in women's health, but then quickly realised I wanted to do a little bit more in terms of medically. And I decided I wanted to do IVF and fertility and infertility way before I had to go through any of that stuff myself. So I did seek it out as soon as I started med school. Our job has, by trade, you have to be an obstetrician gynecologist. So even though I have delivered thousands of babies during training and my first few years as a specialist, I don't do that anymore because I've gone specifically into the fertility endocrinology space. And unfortunately, I live and breathe it, or fortunately, it's so interesting, and to have the privilege, or I don't know if people call it the privilege, but the craziness to go and do a reproductive endocrinology subspecialty on top of specialty really gets you to understand how the body works, how hormones work, but also be able to try and ameliorate the issues associated with infertility. So it's an all-round, really a complex area to work in, but also rewarding as well.
Do you know what struck me? And in my previous job, I was working on a women's health podcast, which is where we first met. And I thought I knew a fair bit about how my own body worked. And I seriously underestimated my education because, for starters, I wasn't even aware. Say, for example, I found out very recently that the egg is fertilized in the fallopian tube and not in the uterus, or that, sperm can head out into the abdominal cavity when it's, gone past the egg and out the other side. There's so many things about our reproductive systems that we are either not taught or it's just not sought out information. Are there still things that surprise you about women's reproductive systems, even though you have lived and breathed this for many years now?
Oh, absolutely. And the thing is, we're a young specialty, right? We've only kind of been around for 40 years. And that's not that young, but compared to other medical specialties that have been around for centuries. So the stuff that we learn is incredible. And reproductive endocrinology is also very much intertwined with genetics. So the ability of our, current day and age to get genetic information and then marry that with our specialty. It's phenomenal, the stuff that we learn every month, every week. And even if that makes a 1% difference to someone's ability to conceive or have a better life and have better reproductive health, that to that person, that 1% could mean a lot. So it's amazing. And I remember doing REI training, reproductive endocrinology training, which I only finished a few years ago, and the exam absolutely sucks, can I say?
I can't even imagine how difficult that is.
And, I would have thought I knew all this stuff, but like you said, there's just so many complex nuances and intricacies that we had to learn. And you just go, oh, wow, can't believe this happens and can't believe anyone actually gets pregnant naturally.
That's the thing, isn't it? It is truly a miracle that any of us exist because so many factors have to align in order for all of that to happen and then for you to grow from those, clump of little cells into an actual human. So many things can happen in that process time.
And it's a miracle. And sometimes you just take a breath, and when it all happens and you just sit in wonder, of how amazing it all is. And because you get caught up in, trying to conceive and your cycles and ovulation and, embryo grading. And, when you sit back and take a breath, it's pretty amazing.
The fact that you can only really, and I say this generally because it's not always the case, but generally you can only fall pregnant in a small window of your cycle. And the fact that people get pregnant by accident all the time is wild to me.
Unbelievable.
Wild.
And so unfair.
So
sometimes.
unfair sometimes. I know
Yes.
when other people are struggling and doing all the right things and it's not happening, it must be incredibly frustrating to watch that happen. But do you remember the first IVF cycle you helped someone become pregnant? Like, does that remain burnt into your brain forever?
Yes. There's a couple of things in life, in our training, that I remember, and that is one, like your first pregnancy, and the two others is my first cesarean section, where I delivered a baby, and my first natural delivery that I assisted with. They're, just from a doctor point of view, they were really, really cool things. Like, it really blows your mind. And the one other thing in med school that I'll always remember was nothing to do with fertility really, but I was assisting in an open heart surgery and being able to hold a heart in your hand, a beating heart. Like, there are some things that you just go, wow, this is incredible. Life is incredible.
How many humans walking on this planet are you responsible for? Do you keep count?
Unfortunately, my two, which I often wonder what happened there, But yeah, no, it is a privilege to be let into someone's life and to ask the most intimate questions and for someone to, allow you to, to have that trust. I'm not saying at all that fertility medicine is easy. In fact, many people don't go into it for the fact that it is so sometimes emotionally draining.
I was going to say it's one of the most
yeah.
emotional, I guess, areas that you can exist in as a doctor, right?
Yeah, it is. And sometimes you don't realize it till the end of the day because you have a lot of patients and you go from 1 second, crying with the patient because you've seen a heartbeat to the next second crying because, it hasn't worked for the 5th time or, or someone's in menopause at the age of 20 or, and you just go from one patient and feeling all of that because you carry every patient with you. Unfortunately or fortunately, this is the job. We have a vested interest in every single person. And we celebrate all of their wins and we also get really sad for their losses, So it is a really tough area sometimes to be in. And I often say, look, if I didn't have the positives, sometimes the negatives can break you. But it's an everyday thing that we deal with and we live and learn as you get, more experienced in the profession.
Okay, you didn't give me a number there, Dr. Dev, but I'm gonna like you don't have to tell me if you've kept a tally, but have you kept a tally, yes or no?
No, no.
Okay.
I do keep a tally of how many cycles I do per year. Well, it's part of our governance. So
Right. So
all of
some things
us,
you're forced to
you
keep
know,
data on,
we
yes.
are. We are.
Yes.
And also, we also want to make sure, like, we're very strong on pregnancy rates. And, we analyze every single aspect of each and every one of us doctors. So we are updated. Well, as the medical director, I have to keep on top of every doctor in our clinic. But I'm the harshest on myself. So I'm very up to date with pregnancy rates and numbers and all the rest of it.
Okay. We talked there for a second about how emotional your job can be. And that's not to say that other, medical fields don't carry as much weight. And I mean, I know someone who's worked in palliative care, which is also incredibly
Absolutely.
emotional. So there's definitely, there's lighter and darker sides of every profession. But something that you do have to do is tell families or deal with families who have had unsuccessful IVF cycles. And for some people, they do that many, many times, and it becomes, I haven't done it personally, but I imagine it doesn't get any easier the second, third, fourth time around. But how do you help people through that? Because that must be something that is a very specific part of your job, that you sort of have to counsel people through that process.
Yeah, I think it's actually it's a bit of I think all doctors do this. They gauge what that person is like and what they need from you. So there are patients who don't want you to, they want the clear facts. They're going to deal with it the way that they want to, and then they, will get on with things. There are a lot of patients who appreciate you holding their hands and, don't mind if you sometimes get a bit emotional with them. That is unfortunate. You can't help it. Some patients, can tell you so many stories of success, but also of the ones that we just couldn't get there, right? And I think it's about building that rapport with the patient and understanding what that patient's like. And the truth is, we don't always get it right. There are some patients and some doctors and some people that you just don't get on with, and that's just how it is. But the majority of the time, it actually comes naturally, I think. It does kind of help, I suppose. Not to say that people who haven't had the experience with IVF or infertility, or who's not a woman, is any worse than I do. But for myself, it has helped having lived experience. I don't actually talk about my experience with my patients unless they ask, but I've been forced to discuss this in media, I suppose, and also, we have our own podcast and things like that. So I have I tend to be a bit private, but being on social media and things like that does bring out that aspect. And generally, I think patients quite like that. They kind of like to know that you're human and, you have the feelings and all the rest of it. And I don't overstep. And the other thing is, we always offer support externally. We have counselors. We have an open book, open phone, email for anyone at any point in time. We have 24-hour, on call. All of those things are to help support women, men, and everyone else if they need us.
Can you step me through exactly what it is you do? So obviously you meet with patients and you understand their journey and what they are after and what they're hoping to achieve. But then what's the practicality of what it is you do? Are you someone who is, sucking up sperm in a syringe and sticking it into an egg and then freezing it? What exactly are you doing?
Look, I do a variety of things, and everyone slightly is different. I suppose my background is that I am a reproductive endocrinologist, so I have a little bit, more physician background, but I'm also a laparoscopic surgeon, so I will operate as well during the day for endometriosis and things like that. So I am able to, when, I get a referral, I look at the referral, I triage it, so I say how urgent it needs to be seen, and then I tell my team to book the patients in. And if the patient's a couple, I really need both patients there. Of course, I will see them if not, but I really encourage that for the patient, because it's a two-way street. But I also have many patients who are single as well. So we create families for all kinds of situations. Then the patients come in and they do a lot of pre-work for me before they come in. And usually my first consult takes about 45 minutes to an hour, and I take a really big history. By the end of that time, I'm able to tell them why I think they haven't gotten pregnant, or some of the barriers, or why they've had miscarriages. I see all kinds of people, like like young teenagers who've gone through menopause because of a genetic condition, or people who've gone through cancer treatment, as well as all the other common reasons for infertility, PMOS, endometriosis, tubal factor, all of those.
Also, just sorry to interrupt, but it's not always up on the woman, right? Because men and their
100%.
sperm need to be taken into account here too.
Exactly. And that's why it's really important the partner comes in. And so by the end of that first session, I generally can tell 99% of the time the barriers or problems associated with their infertility. And in, look, a global generalization, about 30% is male related, 30% is female related, and 30% is a combination. And really, unexplained infertility where I don't have an idea is only about 5% of the time. It's an actual thing, but mostly it's because we haven't found the cause yet. And then I give patients I often ask patients, what are they wanting from me today? And, some patients come in with, I don't want to do anything to do with IVF. I want to do things as naturally as possible, which is very different to someone who comes in and goes, I don't care about the natural stuff. Can you just put me through an IVF cycle, or can you put me through surgery? So I ask what the patient wants. And unless it's unsafe or is really going to reduce their chances, we have this discussion. It's always something, the patients and I make a plan for together, and it has to be individualized. And it takes in a lot of things as age and ovarian reserve. Then, for example, if they want to do something like IVF, I actually do a treatment plan for them, and then they meet my team at Life then and there. So they have meet with the nurses, they get quotes for the procedures, the nurses organise a nurse interview, a scientific interview, etc. And then everything happens in the background. So the patients get ready. The next time I see them could be probably over the phone to go through results, but then it could actually be when they've started an IVF cycle and I do their scan. Once I've done their scan, which is in the rooms, then we organise an egg collection. Egg collection can happen in the hospital or at Life in the clinic. And I go in and I collect the eggs under general anaesthetic or sedation or whatever it is.
Can I stop you for a sec? So basically, when you hear women talking about that they have to take hormone injections, that is to stimulate a whole bunch of eggs to actually do the egg thing, right? And then
That's correct.
Like, are you using like a kick-ass needle in there to suck them out? Like, how does that work?
Yes, it is a kick-ass needle. So the IVF medications, I'm sure you've seen everywhere, but they're tiny. We teach patients how to do it themselves. And it's usually about 11 days or so of injecting yourself. And then when you come to the scan, I just make sure that we're heading in the right direction, change things if we need to. Then during the IVF egg collection procedure, it's a very long needle, about 30 centimetres. And the reason it's long is because it has to go through the vagina. So the vagina's long, right? So it's not because we're trying to be cruel.
And it's not that you're penetrating through layer upon layer. Like are you going in via the vagina? So it's not actually touching anything till it gets to the cervix or wherever it is you're going?
Yes.
Yes.
Through the vagina and the vaginal wall, and then straight to the ovary. And so there's no tummy procedure. It's all vaginally. And then we suck out the eggs on a special kind of equipment. And then they go into little test tubes. And there's like a billion processes between them, as you can imagine. But anyway, it goes to a test tube and the embryologist looks down a microscope in real time and tells us how many eggs we get.
So like then and there, they're like, there's 20 or there's 5 or whatever.
Yeah.
Okay.
Absolutely. And so when the patient wakes up, or if they're awake already, we all know straight away how many eggs we've gotten. And at the same time, if there is a male partner, they will be producing in our lab. And scientists, essentially clean, wash, centrifuge the sperm and get it ready for fertilization with whatever eggs we have.
Wash sperm?
Yeah, so it's called a wash, but it's a special kind of processing of the sperm.
Okay, I imagine that being chucked in the washing machine for a minute, just clean it up a bit before its new date. I don't know. Spiffy it up.
Pretty much. A mini washing machine. But yeah, with lots of special good stuff, and then depending on how we're going to put the egg and the sperm together, we put that together on that day, and then we put it in an incubator for up to 7 days, up to 6 days or so. And then there's lots of checks along the way to see what the egg and the sperm do together. Do they fertilize? Do they create, a day 3 embryo, a day 5 embryo? Do they give us anything at the end to either put back fresh
and
or
when
to freeze?
You say you put them together, are you actually injecting a sperm into an egg, or are you just like launching some sperm at the egg and see what's happening?
Yeah, the latter in most of the cases, in about in 60% of the cases or so. But if there's a semen abnormality, like a sperm abnormality, like a male factor that the sperm doesn't move, for example, we do something called ICSI, which is injecting the egg with the sperm. And when I say we, not me, the clever scientists do that.
I like that because as we've found out more recently, is that it's not a race of the fastest sperm, which is what we were under the impression happened during fertilization, that the first one on arrival is the winner, that the egg is actually quite selective and it says, no, I don't like you, but I quite like you, come on in. So I'm glad that egg gets a chance to make a choice in this situation.
Oh, well, yeah, absolutely. It's a lot to do with the egg, actually. And the egg can overcome a lot of sperm issues and abnormalities as well. The egg's pretty powerful.
We love that. Okay, so once the embryo is fertilized and it starts to do its thing, what's the next steps from there?
So that first 5 days of life in nature would happen in the tube, but in IVF, it happens in the lab. And, a general normal IVF cycle is 10 to 15 eggs will give us a couple of embryos at the end of that week. Now, you do have an option of testing that embryo for genetic or karyotypical abnormalities. There's a lot of things that can happen along the way, but essentially, if you've got an embryo, we would prepare the uterus for transfer. Now, if it's a fresh transfer on day 5, we would put that embryo back in, and it's quite simple, that process. It's just like a pap smear with a tiny little tube with the embryo that goes in. If it's a frozen embryo transfer, we'd freeze that embryo, and on the next cycle, or whenever the patient wants, we would be preparing the lining so that the embryo goes back in. And that's really simple. Often it's just the patient's natural cycle that we kind of modify a little bit, or sometimes we give medication like estrogen. Once the embryo goes back in, that whole process takes like 5 minutes, 10 minutes. Then we do a pregnancy test in 10 days' time.
And that's when we hope
That's it.
the result that we're after.
Yeah.
I also ask this question of my friends who are in the medical profession because I bet you get asked for unsolicited advice all the time.
Yes.
I would like to know, what is the most common question you get asked when people find out that you work in the IVF space?
Well, actually, the most common question is, what does that mean? So, what exactly does an IVF specialist do? Is it just IVF, or what is a fertility? So it's more about what I do and to see, and if it's relevant to the patient, how I could help them, like who or that person. So I think it's more about, it's not smoke and mirrors, I suppose. It's the intricacies of the lab and exactly how amazing that process isn't conveyed so easily, I think, on social media and on online platforms. I think we hear all about the emotional toll and, but the background isn't that obvious. I feel, I don't know what you think, but.
No, I definitely think that the negative stories definitely get the most attention. The hard slog and the difficulties of it definitely get highlighted over the actual process of it.
Yeah, so I think that's the biggest question, and then people ask me a lot about success rates and what it means. Yeah.
Do you have a number that you give yourself for success rate? Is this part of the data that you have to keep on your pregnancy rates? Like, do you go, I have a 80%, 90% success rate?
Yes. Yes, I do. And I do tell, it does vary between how the embryo is given back. So if it's PGTA tested and things like that, look, a lot of us, it's a contentious issue about clinics and how we put the information on the IVF Success website. And it is a great thing. Look, the truth is, I'm on a lot of the boards. I'm on the FSA Australia, Fertility Society Australia board. I'm IVF Medical Directors Group board. I'm on all of these things. It's not 100% these league tables because it doesn't take into account patient factors so well. So I find it a little bit tricky. We, for example, at Life, we are very transparent we have 2 services. We have a low-cost bulk bill service, but also a full service. So controversially, our pregnancy rates just get mixed up. So obviously, some aspects of IVF will give us a lower pregnancy rate than others, but we can't in, an online platform, we're not allowed to say exactly which one is our low cost and which one is our high cost and things like that. So it's very tricky, but in terms of the clinic, we put our pregnancy rates up all the time, and all of us should know our own pregnancy rates, and all of my doctors and teams know their own pregnancy rates. Every 3 months, they are alerted to, because we need to keep an eye on things. If for some reason something drops, we just have to make sure, because you never know, right? It could be some temperature issue in the lab, or, so we're very, very, like, every single day at 6 a.m., we have a quality assurance check of our lab. Like, every single day someone comes in, we have multiple alarms. If a temperature changes by 2 degrees, alarms go off, to the point where our scientific director and myself at 3 a.m. will get an alarm. So, there is so many aspects that we have to look at to maintain those success rates. So, yeah, it's an ongoing process, but yes, we all know exactly, month per month where we're at.
I would love to hear from you whether you feel like the stigma around doing IVF as opposed to conceiving naturally still exists. Because I remember, I was born in 1978, the same year as Louise, the first, I say this in air quotes, test tube baby, which is what she was referred to back then. And there was this real stigma around IVF, like it was some kind of Frankensteinian sort of, awful, against nature kind of vibe to it. And that has definitely decreased over time. But do you feel like that stigma still exists to some degree?
It's a difficult question. I feel like I would give a biased opinion because for me it's so natural, So for me, I don't see the stigma so much, but I do get that patients can feel quite isolated doing IVF. And the actual stigma is really infertility more than IVF, I think, and I don't know if you ever had trouble conceiving or if you tried, or, but I just remember the worry is more yourself and the fact that how you're going to deal with not succeeding with it, and how you're going to live for the rest of your life without something that you really, really want. And so it's kind of almost created because of the situation you're in. And, the stigma is whether you tell people or not. And then when it doesn't work, or if it doesn't work, how you're going to deal with that amongst your friends. Everyone means well. So, look, I certainly don't think it's a Frankensteinian thing or whatever, now, but I think there's a bit of stigma because of infertility per se. Like, what did you do wrong? How could you have prevented it, and things like that, more than IVF as an actual medical treatment.
I would love to, in a perfect world, remove the emotion from conception altogether. Like, how we wait for, until the 12-week mark to share the news just in case, because it's so miscarriage is so common, and yet we've attached all of this emotion to it, and rightly so. It's a human life we're trying to create. That is, that is not taking away from the emotions that attach to that. But we keep that inside of us for that 12 weeks, just on the off chance that something might happen, and then we have to grieve publicly in front of people. I would love to be able to sort of, women be able to just go, you know what, God, my ovaries are not doing what they're supposed to. We're getting a bit of help. It's great. Or, oh my gosh, that pregnancy didn't take. It sucks, but, onwards and upwards. It's not anything to do with me, less womanly, unable to, keep a child. Like, there's so much stigma around women and their bodies not doing what nature intended that sometimes I think we just need to go, you know what, maybe this is what my nature intended, and I'm going to get a bit of help with it.
Exactly. And I try and normalize fertility treatment. Like, I always say, if you had a clogged artery and you had chest pain, what are you going to do? See what happens? No. So same thing. You have got a problem here. Absolutely, you cannot do anything, but you could also treat it, right? So absolutely, we try and do that all the time, actually. And just out of interest, I was watching this lecture last week we have a big European society meeting, and one of the most interesting lectures that was there was from an economist, and it was titled "Our Childless World," and how very realistically, in 50 years, we very well may have a very small amount of children. And that's not just because of infertility, but because of choice, because women aren't supported. We don't have parental leave, or we both have to work so hard in a relationship to give money because it's so expensive to raise children. And, and I just think, the quicker we normalize infertility and the quicker we treat patients who want to have children, the more likelihood we can change things like this happening in the future, which very well may be a reality for us.
Absolutely. And it's, not all about our bodies. We shouldn't be, beating ourselves up over something that we don't have any.
Slack.
Yeah, cut us some slack.
Exactly.
I would love to end today, Dr. Dev, with just some idea on what the latest news is happening in the IVF space. Are there big things happening? Are changes happening? Are we making obviously we're making breakthroughs in this space all the time, but what's the latest?
I guess trying to reverse the age factor is something that everyone's researching rapidly. We don't have an answer to that, but there's a lot of research in the stem cell space and probably incorrectly labelled ovarian rejuvenation. That's not really a thing.
I've heard that bandied around a bit.
Exactly, but mainly to try and get egg quality as best as possible. I think genetics is the biggest thing that's changing, and rapidly our ability to actually diagnose things based on at a molecular level. I think other things like uterine transplants and potentially having uteruses and growing babies externally and things like that. They sound crazy, but I reckon in 10 years' time it's not going to be as crazy as we think.
I want to know what you think, because I did see a headline come out of China that they'd created some kind of robot that had a uterus that could potentially grow an actual human inside it. What do you think when you see things like that?
Look, I think unlikely, but who thought IVF would work, right?
Yeah.
42 years ago.
Yeah.
They started off pretty primitive. So I think we probably will be able to have some form of gestational carrier. I don't know if it would be a robot or if it would be, some kind of a lab thing.
I feel like it's mean to make it look like a human. I mean, we don't have to do that, right?
Yeah, it's already gone a bit far, right? Robots and AI and everything, and our companions, and I don't know.
Yeah.
But I'm a little bit old school sometimes.
So I'd love to ask you too, just finally, I said my last question was my final one, but this one is definitely my final one.
I've got an embryo transfer in 30 seconds. All good.
Okay. Just when you talk about genetics and how far it has come, I know there was a lot of issue around, people choosing genders and even like choosing eye colours and hair, like all this kind of craziness. What are we actually using genetic testing for? Is it truly just to find out whether there is any implications health-wise?
No, not at all. We're in Australia, we are generally, as a global statement, we're quite strict with what we are allowed to and not to do. IVF and fertility is governed quite strictly. So we don't test for gender unless it's a gender-related disease, like, I don't know, haemophilia or something where we know that choosing the gender can reduce the chance of the, child having the disease. So we tend to use it on genetic abnormalities that are known in the family or de novo mutations. But overseas, absolutely, they are doing, PGTPA, so polygenic disease testing. So you can potentially choose embryos that have you a better chance of having, some diseases not in there, like diabetes or even gender, colour, for no actual medical reasons. So yes, we are using that in the world. In Australia, not so much at the moment, but that could change because there is a push from some factors in society saying that if you're paying for it, why not do it? Like, why should we, as doctors or whatever, governance and politicians say no when patients are wanting to do that? But there's so many ethical factors involved in that, are we creating a perfect child? And, what happens then to people who can't afford to do that? And anyway, the debates are continuing. But yes, we are using all of those technologies, actually. It's just not as perfect science yet.
Well, Dr. Dev, I shall not keep your patient waiting any longer. Thank you so much. Again, happy World IVF Day. Thank you for helping the families that you do. And thank you so much for sharing your insider knowledge on it. Appreciate it.
Thanks, Claire. Lovely to speak to you again.
That's it for your Saturday special today, folks. For everyone who has ever undergone IVF, whether successfully or not, shout out to you for being such a badass and having that ginormous needle up your nethers to harvest those eggs. You are a boss. Thanks for listening today, folks. We're back Monday to do this all over again. Enjoy the rest of your weekend. Bye.